And welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 32, Drug Abuse, Nicotine, and Smoking. So, touching up on nicotine and smoking. Cigarette smoking remains the greatest single cause of preventable illness and premature death. In the US, smoking kills more than 443,000 adults annually, and about one of every five deaths. Around the world, tobacco kills more than 5 million people annually. On average, male smokers die 13.2 years prematurely, and female smokers die 14.5 years prematurely. Accordingly to the CDC, most deaths do result from lung cancer, heart disease, chronic airway obstruction. Not only do cigarettes kill people who smoke, but also every year through secondhand smoke. Cigarettes kill about 50,000 non-smoking Americans and 600,000 non-smokers annually worldwide. The direct medical cost of smoking exceeds $95 billion annually. Indirect costs include lost time from work and disability. Add up to the additional $97 billion in the US, the prevalence of smoking among adults fell steadily from 1965 through the 1980s and 90s, but decreased only slightly between 2004 and 2013. Although tobacco smoke contains many dangerous compounds, nicotine is of greatest concern. Other hazardous components in smoking include carbon monoxide, hydrogen cyanide, ammonia, nitrosamines, and tar. Tar is composed of various polycyclic hydrocarbons, some of which are proven carcinogen. Until recently, cigarettes had avoided virtually all federal regulations. However, strong regulations are now in place. Under the Family Smoking Prevention and Tobacco Control Act, passed in June of 2009, the FDA now has the authority to undertake the following: strengthen advertising restrictions, including the prohibition on marketing to the youth, require revised and prominent warning labels, require disclosure of all ingredients in tobacco products and restrict harmful additives, and monitor nicotine yields and mandate gradual nicotine reduction to non-addictive levels. So, the pharmacology behind nicotine, its mechanism of action. The effects of nicotine results from actions at nicotine receptors. Whether these receptors are activated or inhibited depends on nicotine dosage. Low doses activate nicotine receptors while a high dose can block them. The amount of nicotine received from cigarettes is relatively low. According to cigarette smoking causes receptor activation. Nicotine can activate nicotinic receptors at several locations. Most effects result from activating nicotine receptors in autonomic ganglia and the adrenal medulla. In addition, nicotine can activate nicotinic receptors in the carotid body, aortic arch, and central nervous system. As discussed later, actions in the CNS mimic those of cocaine and other highly addictive substances. When present at the levels produced by smoking, nicotine has no significant effects on nicotine receptors of the neuromuscular junction. The pharmacokinetic absorption of nicotine depends on whether the delivery system is a cigarette or a cigar or smokeless tobacco. Nicotine in cigarette smoke is absorbed primarily from the lungs. When cigarette smoke is inhaled, between 90 to 98% of nicotine in the lungs enters the blood. Unlike nicotine in cigarette smoke, nicotine in cigar smoke is absorbed primarily from the mouth, as in nicotine in smokeless tobacco. Nicotine can cross membranes easily and is widely distributed throughout the body. When inhaled in cigarette smoke, nicotine reaches the brain in just 10 seconds. Nicotine is rapidly metabolized to inactive products. Nicotine and its metabolites are excreted by the kidney. The drug's half-life is 1 to 2 hours. Pharmacologic effects. The pharmacologic effects discussed in this section are associated with low doses of nicotine. These are the effects caused by smoking cigarettes. Responses to high doses are discussed later under acute poisoning. Cardiovascular effects. The cardiovascular effects of nicotine result primarily from activating nicotinic receptors in sympathetic ganglia and the adrenal medulla. Activation of these receptors promote release of norepinephrine from sympathetic nerves and the release of epinephrine from the adrenals. Norepinephrine and epinephrine act on the cardiovascular system to constrict blood vessels, accelerate the heart, and increase the force of ventricular contraction. The net result is elevation of blood pressure and increased cardiac work. These effects are underlie cardiovascular death. The gastrointestinal effect. Nicotine influences gastrointestinal function primarily by activating nicotine receptors in the parasympathetic ganglia, thereby increasing secretion of gastric acid and augmenting tone and motility of the GI smooth muscle. In addition, nicotine can promote vomiting. Nicotine-induced vomiting results from a complex process that involves nicotinic receptors in the aortic arch, carotid sinus, and CNS. The central nervous system effects. Nicotine is a CNS stimulant. The drug stimulates respiration and produces an arousal pattern on the electroencephalograph. Moderate doses can cause tremors, and high doses can cause convulsions. Nicotine has multiple psychological effects. The drug increases alertness, facilitates memory, improves cognition, reduces aggression, and suppresses appetite. In addition, by promoting the release of dopamine, nicotine activates the brain's pleasure system, located in the mesolimbic area. The effects of nicotine on the pleasure system are identical to those of highly addictive drugs, including cocaine, amphetamines, and opioids. Effects during pregnancy and lactation. Nicotine exposure during gestation can cause harm to the fetus. The nicotine in breast milk can harm the nursing infant. Nonetheless, because pharmaceutical nicotine is safer than tobacco smoke, it is reasonable to consider using nicotine therapy during pregnancy to help the patient quit smoking. Tolerance and dependence. Tolerance develops to some effects of nicotine, but not to others. Tolerance does develop to nausea and dizziness, which are common in the novice smoker. In contrast, very little tolerance develops to the cardiovascular effects. Long-term smokers continue to experience increased blood pressure and increased cardiac work whenever they smoke. Dependence. Chronic cigarette smoking results in dependence. By definition, this means that individuals who discontinue smoking will experience an abstinence syndrome. Prominent symptoms are craving, nervousness, restlessness, irritability, impatience, increased hostility, insomnia, impaired contractions, or concentration rather, increased appetite, and weight gain. Symptoms begin 24 hours after smoking has ceased and can last for weeks to months. Women report more discomfort than men. Experience has shown that abrupt discontinuation may be preferable to gradual reduction. The acute poisoning. Nicotine is highly toxic. Doses as low as 40 milligrams can be fatal. Toxicity is underscored by the use of nicotine as an insecticide. Common causes of nicotine poisoning include ingestion of tobacco by children and the exposure to nicotine-containing insecticides. So what kind of symptoms would we see then? The most prominent symptoms involve the cardiovascular, GI, and central nervous system. Specific symptoms include nausea, salivation, vomiting, diarrhea, cold sweat, disturbed hearing and vision, confusion and faintness. Pulses may be rapid, weak, and irregular. Death results from respiratory paralysis, which is caused by direct effects of nicotine on the muscles of respiration, as well as by the effects in the CNS. Treatment. Management centers are reducing nicotine absorption and supporting respiration. There is no specific antidote to nicotine poisoning. Absorption in ingested nicotine can be reduced by giving activated charcoal. If respiration is depressed, ventilation assistance is indicated. Because nicotine undergoes rapid metabolism inactivation, recovery from the acute phase of poisoning can occur within hours. Chronic toxicity from smoking. It is now clear that chronic smoking can injure nearly every organ of the body. Smoking causes cardiovascular disease, including abdominal aortic aneurysms, chronic lung disease, and cancers of the larynx, cervix, kidney, pancreas, stomach, lung, esophagus, oral cavity, and bladder. Leukemia, cataracts, pneumonia, periodontal disease, and type 2 diabetes are also related to smoking. Smoking during pregnancy increases the risk for low birth weight, preterm labor, stillbirth, miscarriages, spontaneous abortions, perinatal mortality, and sudden infant death. The leading cause of smoking-related death are lung cancers, ischemic heart disease, and chronic airway obstruction. So, the prototype drugs that we'll discuss in this chapter include the nicotine patch and nicotine-free products. So, the pharmacologic aids to smoking cessation. Cigarettes are highly addictive, which makes giving them up very hard. Nonetheless, abstinence can be achieved. Every year, about 41% of Americans who smoke make one or more attempts to quit. Of those who try to quit without formal help, only 4 to 7% achieve long-term success. In contrast, when combination of counseling and drugs is employed, the 6-month abstinence rate approaches 25%. However, even with the aid of counseling and drugs, the first attempt usually fails. In fact, most people try quitting 5 to 7 times before they ultimately succeed. As time without cigarettes increases, the chance of relapse gets progressively smaller. Of those who quit for a year, only 50% smoke again, and for those who quit for 5 years, only 3% smoke again. Long-term smokers should be assured that quitting offers important health benefits, regardless of how long you have smoked. Quitting can reduce the risk for developing a tobacco-related disease, slow the progression of an established tobacco-related disease, and increase life expectancy. These benefits apply to only those people who quit while they were young and healthy, but also to people who quit after the age of 65, and to those who establish tobacco-related disease. Data from the Nurses' Health Study indicate that former smokers eventually achieve the same disease risk status as never smokers, even with respect to lung cancer. The risk for chronic obstructive pulmonary disease or death from a heart attack declines to that of never smokers in 20 years, and the risk for lung cancer reaches that of a never smoker in 30 years. 7 drug products have been shown to aid smoking cessation, which are in the following table. Of these 7 products, 5 contain nicotine and 2 do not. The nicotine-based products, nicotine gum, nicotine lozenge, nicotine patches, and inhalers, as well as a nasal spray, are employed as nicotine replacement therapy. The 2 other products are sustained-release bupropion and varenicline, as taken to decrease nicotine cravings and suppress symptoms of withdrawal. The most effective drug therapy for smoking cessation are varenicline, also known as Chantix, alone, and the nicotine patch combined with a short-acting nicotine product. At this time, we cannot predict who will respond best to a particular product. Accordingly, selection should be based on the patient's preference, success with a particular product in the past, and side effects. So here's an excellent spot to hit pause so you can review the different types of options available, their common side effects, advantages and disadvantages, its preparation, and the adult use, and usually the length of use. So I'll leave that up, and here's probably a good spot to see just about all of it. Interventions for smoking cessation can be found in Treating Tobacco Use and Dependence, the 2008 update, a clinical practice guideline issued by the U.S. Public Health Service. As stated in this guideline, tobacco dependence is a chronic condition that warrants repeated intervention until long-term abstinence is achieved. This is the same philosophy that guides treatment of dependence on other highly addictive substances, including cocaine and heroin. Tobacco dependence can be treated with 2 methods, drugs and counseling. Both methods are effective, but a combination of both is even more effective than either one alone. According to the guidelines, recommended that all patients who want to quit be offered at least 1 smoking cessation drug along with counseling, be it one-on-one, in group, or over the phone. The overall intervention strategy is summarized in the 5 A's model for treating tobacco use and dependence. Ask, advise tobacco users to quit. Assess willingness to make a quit attempt. Assist in quitting. Arrange follow-up contacts, beginning with the first week after the quit date. For additional information on smoking cessation, there is a website here for both Canada and the United States. Again, an excellent spot to hit pause if you're looking to quit on how to smoke or quit smoking. Nicotine replacement therapy, or NRT, allows smokers to substitute a pharmaceutical source of nicotine for nicotine in cigarettes, and then gradually withdraw the replacement nicotine. This is analogous to using methadone to wean addicts from heroin. The FDA-approved formulations available include chewing gum, lozenges, transdermal patches, nasal spray, and inhalers. With the gum, lozenges, patches, and inhalers, blood levels of nicotine rise slowly and remain relatively steady. Because nicotine levels rise slowly, the delivery system produces less pleasurable effects than cigarettes, but nonetheless, they do relieve symptoms of withdrawal. With the nasal spray, blood levels of nicotine rise rapidly, much as they do if you are smoking. Therefore, the nasal spray provides some of the subjective pleasure that smoking does. Long-term quit rates are significantly greater with NRTs than with a placebo, although absolute success rates continue to remain low. An example of this is the one-year success with a nicotine patch is about 25%, compared with 9% for its placebo. Success rates are highest when replacement therapy is combined again with counseling. Nicotine products are classified in the FDA pregnancy risk group of category C or D, depending on its type. Accordingly, they should generally be avoided during pregnancy. However, because smoking is probably more harmful than NRT, the use of NRT during pregnancy is worth consideration. Which brings us to the chewing gum of nicotine. Nicotine chewing gum, or Nicorette, is composed of a gum base plus nicotine polacrylates, an ion exchange resin to which nicotine is bound. The gum must be chewed to release the nicotine. After its release, nicotine is absorbed across the oral mucosa and to the systemic circulation. Like other forms of NRTs, nicotine gum doubles the cessation success rate. The most common adverse effects are mouth and throat soreness, jaw muscle ache, eructation, and hiccups. Using optimal chewing technique minimizes these issues. Patients should be advised to chew the gum slowly and intermittently for about 30 minutes. Rapid chewing can release too much nicotine at one time, resulting in effects similar to those of excessive smoking. Because food and beverages can reduce nicotine absorption, patients should not eat or drink while chewing or for about 15 minutes before chewing. After 3 months without cigarettes, patients should discontinue the nicotine use. Withdrawal should be done gradually. The use of nicotine gum beyond 6 months is not recommended. The lozenge. The pharmacology of nicotine lozenges is very similar to that of the nicotine gum. Both products contain nicotine bound to the polacrylates. Sucking on the lozenge releases nicotine, which is then absorbed again across the oral mucosa into the systemic circulation. Similar to the nicotine gum and other forms of NRTs, the lozenges double the success in cessation rates. The most common adverse effects are mouth irritation, dyspepsia, nausea, and hiccups. Again, all of which can be made worse by taking 2 lozenges at once or by taking several lozenges in immediate succession. Administration consists of placing the lozenge in the mouth and allowing it to dissolve, which takes 20 to 30 minutes. Users should not eat or drink for 15 minutes before dosing and while the lozenge is in the mouth. Also, they should not chew or swallow the medication. The transdermal patches. Nicotine transdermal patches systems are nicotine-containing adhesive patches that are applied to the skin. Slowly release the nicotine content. The nicotine is absorbed into the skin and then into the blood, producing a steady blood level. The use of the patch about doubles the cessation success rate. Nicoderm CQ can be purchased without a prescription. As indicated in Table 32.3, the patches come in different sizes. The larger the patch size, the more nicotine is released. So here's a good spot to hit pause if you're unfamiliar with different transdermal patch sizes. Nicotine patches are applied once a day to clean, dry, non-hairy skin of the upper body or upper arm. The site should be changed daily and not reused for at least 1 week. The Nicotine patches are left in place for 24 hours and then immediately replaced with a new one. Most patients begin with a large patch and then use a progressively smaller patch over several weeks. Certain patients should begin with a smaller patch, especially if they weigh less than 100 pounds or smoke less than half a pack per day, or if they have any kind of cardiovascular disease. Adverse effects are generally mild. Short-lived erythema, itching, and burning occur under the patch in 35 to 50% of users. In the 14 to 17% of users, persistent erythema can occur, lasting up to 24 hours after the patch already has been removed. Patients who experience severe persistent local reactions should discontinue the patch and contact a physician or nurse practitioner. Speaking on the nicotine inhaler. The nicotine inhaler differs from other NRT products in that it looks much like a cigarette. Puffing on it delivers the nicotine. Because of the delivery method, using the inhaler can substitute for hand-to-mouth behavior of smoking. In addition to nicotine, the inhaler contains methanol, whose purpose is to create a sensation in the back of the throat reminiscent of that caused by smoke. Like other forms of NRTs, the inhaler doubles cessation success rates. The nicotine inhaler consists of a mouthpiece and a sealed tubular cartridge. Inside that cartridge is a porous plug containing 10 milligrams of nicotine. Inserting the cartridge into the mouthpiece breaks the seal. Puffing on the mouthpiece draws air over the plug, and thereby draws nicotine vapor into the mouth. Most of the nicotine is absorbed through the oral mucosa and not in the lungs, and as a result, your blood levels rise slowly and peak in 10 to 15 minutes after puffing stops. Your blood levels are less than those achieved from cigarettes. Each cartridge delivers about 300 to 400 puffs. However, adverse effects are mild, and the most frequent are dyspepsia, coughing, throat irritation, oral burning, and rhinitis. The inhaler should not be used by patients who have asthma. Because the cartridge contains dangerous amounts of nicotine, they should be kept away from children and animals. And finally, nicotine nasal spray. Again, it differs from other NRT formulations in that the blood levels of nicotine will rise rapidly after each administration, therefore closely simulating smoking. Because nicotine levels rise rapidly, the spray provides some of the subjective pleasure associated with cigarettes. As with other forms of NRTs, the spray doubles the smoking cessation rate. Quitting success with the spray has been good news and bad news. The good news, as reported in one study, is that 27% of users avoided smoking within or for at least 1 year. About twice the abstinence rate achieved with a placebo. The bad news is that many patients continue to use the spray, being unwilling or unable to give it up. Nonetheless, because the spray delivers nicotine without the additional hazards in cigarettes, using the spray is clearly preferable to smoking. Adverse effects are mild and temporary. At first, most users experience rhinitis, sneezing, coughing, watery eyes, and nasal and throat irritation. Fortunately, these effects abate in a few days. Nicotine nasal spray should be avoided by patients with sinus problems, allergies, or asthma. Which brings us to bupropion SR, which is an atypical antidepressant, which was the first non-nicotine drug approved as an aid to smoking cessation. The drug is structurally similar to amphetamine, and like amphetamines, causes CNS stimulation and suppresses appetite. In people trying to quit smoking, bupropion reduces the urge to smoke and reduces some symptoms of nicotine withdrawal. The drug is effective in the presence and absence of depression. Although the mechanism of action is uncertain, benefits may derive from blocking uptake of the norepinephrine and dopamine for use in depression. Bupropion is sold under the trade name Wellbutrin. Like other NRT products, Wellbutrin doubles the success in the cessation rate. In one trial, patients were given bupropion SR or a placebo. At 7 weeks, abstinence rates were 19% with the placebo and 29, 39, and 44% with increasing dosages of bupropion SR. At 12 weeks, abstinence rates were lower, 12% with the placebo, 20, 23, and 23 with increasing dosage of Wellbutrin. Combining a nicotine patch with Wellbutrin is somewhat more effective than either treatment was alone. Adverse effects are generally mild. The most common was dry mouth and insomnia in high doses, which were associated with a 0.4% risk for seizures. However, at the doses employed for smoking cessation, seizures were not reported. Nonetheless, Wellbutrin should be avoided in patients with seizure risk factors, such as head trauma, history of seizures, anorexia nervosa, cocaine use, and alcohol withdrawal. Because it suppresses appetite, Wellbutrin can cause weight loss. Wellbutrin should not be combined with a monoamine oxidase inhibitor, nor should it be given to patients taking Wellbutrin, which is just another name for bupropion itself. The basic pharmacology of Wellbutrin will be discussed in further detail in Chapter 32. Varenicline, or Chantix. Chantix is a partial agonist at nicotine receptors. It is our most effective aid in smoking cessation. In clinical trials, more patients achieved abstinence with Chantix than with bupropion, or Wellbutrin, or the nicotine patch. Estimated abstinence rates after 6 months were 33.2% with Chantix and 24.2% with Wellbutrin, and 23.4% with a nicotine patch. The most common side effect was nausea. The most troubling side effect are the psychological changes, since unlike Wellbutrin and NRTs, Chantix does not cause weight loss. So how does it work? Chantix acts as a partial agonist at a subset of nicotine receptors, known as the alpha 4 beta 2 nicotine receptor, whose activation promotes the release of dopamine, the compound that mediates the pleasurable effects of nicotine. Compared with nicotine, Chantix binds alpha 4 beta 2 receptors with greater affinity. Therefore, when Chantix is present, access of nicotine to these receptors is blocked. Because Chantix is a partial agonist, receptors binding result in mild activation, promote some dopamine release, and therefore help reduce both nicotine cravings and the intensity of withdrawal symptoms. At the same time, the presence of Chantix prevents intense receptor activation by nicotine itself, and therefore blocks the reward that nicotine can provide. So, its pharmacokinetics. Chantix is readily absorbed from the GI tract, both in the presence and absence of food. Plasma levels peak about 4 hours after dosing. Binding to plasma proteins is low, only 20%. Metabolism is minimal, and therefore most of the dose, about 92%, is excreted unchanged in the urine. Its half-life is anywhere between 17 to 24 hours, and moderate to severe renal impairment delays excretion and increases Chantix's blood levels. It does, however, have adverse effects. In the clinical trial, dose-dependent nausea was the most common adverse effect, which occurred in about 30 to 40% of users. Nausea was mild to moderate initially and became less severe over time. Other common reactions did include sleep disturbances, headaches, abnormal dreams, constipation, dry mouth, gas, vomiting, and an altered sense of taste. Mild physical dependence started to develop, but there have been no reports of abuse or addictive behavior. Rarely, Chantix had been associated with seizures, diabetes, dizziness, disturbed vision, and moderate or severe skin reactions, although a causal relationship has not been established. In 2011, the FDA warned that Chantix can increase the risk for cardiovascular events in patients with stable cardiovascular disease. After that, a Canadian study revealed a similar risk in patients even though they did not have cardiovascular disease. Fortunately, cardiovascular risk appeared to be small, much smaller than the risk posed by smoking. Nonetheless, patients should be warned about the cardiovascular risk and be instructed to notify the prescriber if they experience any new or worsening cardiovascular symptoms, and should seek immediate medical attention if symptoms of a myocardial infarction do appear. Owing to the concerns about unpredictable physical and psychiatric adverse effects, The U.S. authorities have banned use of Chantix by truck drivers, bus drivers, airplane pilots, and air traffic controllers. So, its preparation, dosage, and administration. There is a black box warning on both Wellbutrin and Chantix. Post-marketing reports indicated that both Wellbutrin and Chantix can cause serious neuropsychiatric effects, which included mood changes, erratic behavior, and suicidal behaviors. All patients should be advised to contact their prescriber if they experience a significant change in behavior or mental status. Wellbutrin and Chantix should be used with caution in patients with a history of psychiatric disease. Products that are not recommended. According to the Treating Tobacco Use and Dependence, the 2008 update, there is insufficient proof to recommend the following drugs to aid to smoking cessation: naltrexone, sulfur acetate, beta blockers, benzodiazepines, antidepressants, and other Wellbutrin SRs, including the selective serotonin reuptake inhibitors. Although not mentioned in the 2008 update, electronic cigarettes or e-cigarettes should be avoided. E-cigarettes are battery-powered, cigarette-shaped devices that release a puff of vaporized nicotine, sometimes together with flavoring and other chemicals. According to the analysis conducted by the FDA, the amount of nicotine per puff can vary widely, and the vapor may contain trace amounts of diethylene glycol and other contaminants. E-cigarettes are promoted on the internet as aids to quit smoking, but are not FDA approved for this use. At this writing, the FDA is attempting to regulate e-cigarettes as drug delivery devices, but is meeting resistance from the court. The bottom line, because the dose of nicotine with e-cigarettes is unpredictable, and because data on safety and efficacy are lacking, the use of e-cigarettes should be discouraged, especially because products of known safety and efficacy are currently available. And that concludes our chapter here today. I thank you as always for listening, and I'll see you at the next chapter, chapter 33. Till then, I thank you for listening. Have a good day.